Hello, I'm David Wallace, founder of PV Reporter and our nonprofit sister organization, MPN Cancer Connection. I'm a 14-year PV cancer survivor and your host for today's Patients Are Asking program. We would like to thank our sponsors, Pharma Essentia, Morphosis, AbbVie, Insight, and GlaxoSmithKline for their support of today's program. We're very pleased to welcome back NPN expert Dr. Geith Abu-Zeinah. Doctor, please give us an introduction.
Thank you, David, for having me again. My name is Geith Abu-Zeinah. I am an assistant professor at Weill Cornell Medicine, the Silver MPN Center. My clinical practice and my research is focused on treating MPN patients and hopefully one day finding a cure for these diseases.
Okay. So in recent conferences, I've been hearing more about disease modification in MPNs. So tell us what the term means and what are the possible implications for patients moving forward?
Ooh, that's a tough question. We get asked this question so often, but I don't think I've found the perfect answer for it. I will say that a disease-modifying drug, at least in my opinion, is a drug that can be specifically targeting of the disease-initiating stem cells that lead to MPN phenotypes, and that over time, that specific targeting of these disease-initiating stem cells will lead to regression of the disease clinically, and therefore improving, all the complications that are associated with the disease. And so there are treatments that could potentially improve symptoms. They could improve blood counts. They could improve splenomegaly and sometimes even fibrosis. But, I think the distinction comes with the fact that biologically a disease-modifying drug is one that is a selective a drug against the MPN clone and not a cell poison that can really poison MPN and normal cells. So you want a drug that is specifically targeting the MPN stem cells and therefore leading to all the improved clinical outcomes, with the key, I think, being prolonging the patient survival on the long term.
Okay, so why is it important for individuals with MPNs to track and document their symptoms before visiting their doctor? And can you share a success story where symptom tracking played a significant role in a patient's diagnosis or their treatment plan?
I think tracking symptoms is important for both the physician and the patient. I think our routine kind of question of how are you doing when a patient comes into clinic can sometimes, not capture really the many symptoms that patients could be experiencing. I think it's very important to have a comprehensive symptom assessment that's not only done face-to-face by asking that question. I think patients should be actually receiving MPN symptom surveys. These are the MPN symptom assessment forms that have been developed by Ruben Mesa and Robin Scherber and others, and have been validated for use in clinical trials as an objective way to measure various symptoms that patients can experience. I think it is key to actually, whenever able, to have patients have access to these forms and fill out these forms at pre-specified intervals, whether it be every 3 months or every time they go to see their clinician, to have that symptom assessment filled out. And that way that could provide data for both the physician and the patient to track their symptom severity, and then have a discussion in clinic about those results at the time of the visit. I think that would certainly make that a lot more efficient for patients to actually have that done in advance and for them to discuss the results with their physician and have an objective measurement that can be tracked over time. So from our experience, I guess what I would say is when patients have the opportunity to fill out their symptoms and we can track them, there are times where the symptoms actually dictate the treatment plan and or potentially alter a treatment plan that might otherwise seem okay. So there are patients who perhaps may have achieved a complete hematologic response, whether they have PV, ET, or even myelofibrosis. Their blood counts, on paper, everything looks good. On exam, perhaps the spleen is, under control, but there are certain symptoms that don't seem to be well covered. And a common example is itching or pruritus. So, you could have PV patients with well-controlled blood counts who continue to have aquagenic pruritus, so itching after showers or just itching in general. And that might sometimes by itself determine the potential need for adding another therapy that could perhaps control that specific symptom.
You make an excellent point on the itching, which kind of brings up a question that I had. A lot of times patients feel like the ultimate goal in their treatment, maybe more so with PV or ET, is to make sure that their counts are controlled and, hey, I've got perfect counts, everything is good. But when I talk to some of these folks, I'll say, well, how are you feeling? And then they'll complain that they've got, problems with itching, problems with concentration, and so on and so forth. So how do you explain the fact that perfect counts don't always equal, you're going to be feeling great?
Yeah, that's also a great question, David. The correlation or lack thereof of blood counts and symptoms is something that really continues to trouble us in clinical practice, because there is sort of an expectation, which may not be correct. It's a preconceived expectation that normalizing blood counts would address all symptoms, and therefore symptoms that emerge in somebody who has normal blood counts would therefore be due to something else. I think it is very important to actually keep an open mind and think about other things, because some of the symptoms that MPN patients experience do overlap with other diseases. What I always do kind of when these symptoms emerge in patients who have normal blood counts is I do favor first thinking about all alternative causes, because potentially the expectation that normal blood counts comes with, resolution of symptoms. I think about other potential causes that might need a workup. There might be additional testing to be done. And once you've confidently ruled out other associated or not associated diseases that could be causing symptoms, then we can kind of go back to the MPN and address why perhaps symptoms could emerge despite normal counts and what we can do about it. As a kind of a perfect example, something that we at Cornell have been looking at as well, our collaborators at Cornell as well, have been looking at is pulmonary hypertension. So pulmonary hypertension is think of it as a cardiac and pulmonary complication associated with MPNs. It's essentially elevated pressure in the pulmonary circulation due to mechanisms that are not totally understood, but it is seen in significantly higher frequency in patients with MPNs. And that condition causes significant dyspnea, which is shortness of breath. It causes, fatigue, and really patients feel winded very quickly. And, in some of our preliminary analyses, and actually are published, we have our group has a published paper on this. It can be seen as common as 50% of cases. Recognizing that that is a potential complication, it's very important that a patient who comes in normal blood count says, I feel short of breath and I'm winded, perhaps might need an evaluation for pulmonary hypertension that includes an echocardiogram or other testing. So I think at first we should always take a step back and think broadly. And then, if all of these kind of other potential causes have been ruled out, and there is a lingering symptom that is clearly linked to the disease despite normal blood counts, then sometimes that perhaps requires a change in therapy.
So it's really an exciting time in the development of new treatments for MPNs. So please give us an update on the most promising late-stage clinical trials.
All right. So by late stage, we typically refer to phase 3 clinical trials. So phase 3 is the last phase of clinical trial development for a drug before the drug is submitted for FDA approval. So, I will say that of all the phase 3 trials right now, I think, and there's 5 in particular that I'll mention and go over. To my knowledge, we really don't have any results that are public yet. Certainly, a lot of these trials have enrolled patients and have enrolled, perhaps they're close to they're completing their accrual, but we do not have any results as of yet. But the studies to keep an eye out for, I think, primarily in myelofibrosis, and there's a study in PV. So in some of our prior discussions, David, we had, I think it was actually last December when we talked about some abstracts at ASH. We had talked about 2 drugs in myelofibrosis that are now in phase 3, but we talked about the phase 2 results. The 2 drugs, the first one is pelabresib, which is a BET inhibitor. And pelabresib is actually now in a phase 3 study called the MANIFEST-2 study. This is a randomized controlled trial that randomizes patients to either receiving pelabresib plus ruxolitinib, or ruxolitinib plus placebo. And so this is an ongoing study looking at of course, the safety, but primarily the efficacy of using pelabresib in combination with ruxolitinib for patients with myelofibrosis. And this, of course, is enrolling patients who are ruxolitinib naive, meaning they've not received ruxolitinib previously. So we'll look forward to the results of this BET inhibitor, which in phase 2 had shown effective in improving anemia in patients and actually achieving transfusion independence in some anemic myelofibrosis patients who require blood transfusions. So it has been effective in treating anemia. It also had shown efficacy in improving patient symptoms, of course, and spleen size reduction. There is actually some perhaps evidence as well of it being a quote-unquote disease-modifying drug, which you asked about earlier, although I think it's still a bit early and the evidence is not robust yet, but I think there's some signal that this drug could be perhaps a disease-modifying agent by virtue of some of the bone marrow responses it has achieved, the bone marrow fibrosis reversion achieved with this drug, and some of the molecular data as far as the allele frequency changes. So that's as far as pelabresib goes. Now, the second drug, navitoclax, which is now in the TRANSFORM-2 phase 3 studies, a randomized controlled study with a similar design in that it's randomized for patients receiving navitoclax with ruxolitinib or ruxolitinib plus placebo, with similar endpoints being the ones that we're very used to, which are symptom improvement, spleen size reduction, as well as other clinical parameters or hematologic responses. This is I didn't mention mechanism, but the navitoclax drug is a BCL2 BCL-XL inhibitor. Essentially, these are cell cycle proteins, and inhibiting these proteins can perhaps favor the kind of the demise of the cancer cells over normal cells over time. So, perhaps this is a drug that could target MPN stem cells and could be disease modifying, but I think the verdict's still out there. The results in the phase 2 have also been quite exciting and promising, with some patients achieving, hematologic responses. Primarily, I would say spleen responses. There's about also a third of patients who've perhaps had bone marrow fibrosis reversion. So there's some, again, exciting results there in the phase 2. So we'll look forward to the phase 3 results to determine if using navitoclax in combination with ruxolitinib upfront is superior to ruxolitinib alone. So I think these two studies are interesting and actually novel in a sense that not only is a drug novel and almost getting there, now it's in phase 3, but the idea is novel in combining a drug with a JAK inhibitor upfront in myelofibrosis therapy. As far as myelofibrosis goes, there's another study on imetelstat, which is a telomerase inhibitor. The study is called Impact MF. This is led by John Mascarenhas. And at EHA, there was an abstract about the study, the study design, but we are awaiting results of this. And this is also a randomized trial, but this is imetelstat as a single agent drug, not in combination, in patients who have previously been on ruxolitinib and have either been resistant to the drug or intolerant to the drug. Once they get on the study, they get randomized to receiving imetelstat, which is an IV drug given every 3 weeks, or they get randomized to best available therapy. So moving on to 2 more studies, actually, there's one that I missed, I didn't talk about in myelofibrosis also, and that is luspatercept. So luspatercept is actually it's a drug that's FDA approved to treat MDS, MPN overlap syndromes and some forms of MDS or myelodysplastic syndrome. It's not FDA approved to treat myelofibrosis, but it is in clinical trial for myelofibrosis. And there is, I believe, the Independence trial, which is the phase 3 study that will be looking at luspatercept in myelofibrosis. Luspatercept is what we call a ligand trap or ligand trap. It's particularly a ligand trap for TGF-beta superfamily proteins. TGF-beta, for those who aren't familiar, is basically a signaling axis that is overactivated in patients with MPNs and is sort of, think of it like cytokine signaling. And TGF-beta cytokine signaling is involved in the pathogenesis of fibrosis and the pathogenesis of, megakaryocyte, hyperplasia development, and essentially the phenotype of MPNs. So luspatercept as a TGF-beta superfamily ligand trap, there's some rationale to using it in MPN patients because of the overexpression of TGF-beta. And it's particularly helpful perhaps in the treatment of anemia. And so there's actually a paper published by our group at Cornell in Blood in 2021 that actually looked at TGF-beta in erythropoiesis and its role in regulating the production of red cells and in inhibiting TGF-beta in treating anemias. And so there is scientific rationale both from our group and from others behind the idea of inhibiting TGF-beta. And this ligand trap for the TGF-beta superfamily proteins has been shown and demonstrated to improve anemia in myelodysplastic syndromes. And there's some preliminary data to suggest that it has effectiveness as well in treatment of anemia related to myelofibrosis. So we'll be keeping an eye on that. Yes, the drug is available on the market for a different indication, but it is now should be in phase 3 study for myelofibrosis. Now, lastly, phase 3 study in Polycythemia Vera, so the Verify study. This is one that I know many are excited to hear about because we've heard a lot about the results of the phase 2 in the past two years or so, about how PV patients can become phlebotomy independent potentially by receiving this therapy. So I think that's quite exciting. I think I could tell you that perhaps many hematologists and patients share my hatred for phlebotomy.
Yes.
It's a necessary evil, right? It is a necessary evil, but I think of it, I personally think of it as a temporary treatment until something better comes along. And I think that perhaps the rusfertide drug can now be the thing that comes along to potentially replace phlebotomy. Now, is it, there's going to be a lot of questions about, down the line, whether that would actually replace it as a standard of care, or whether, it is worth the cost. And we don't know, of course, what it's going to cost. But I think there is rationale in using this drug in patients, at least who have been so dependent in phlebotomies and just, don't respond to first-line drugs. And the first-line drugs, cytoreductive agents include interferons and hydroxyurea, but there are patients who continue to require phlebotomies who might benefit from rusfertide either in addition to or instead of cytoreductive agents. But I think where it fits in the treatment paradigm for PV is yet to be, examined, pending whether the drug will actually, make it all the way to the finish line. But based on the phase 2 results, it seems like a promising active agent. And we are waiting for the results of the phase 3 study, which is randomizing patients to receiving rusfertide or placebo, but with the potential for crossover from placebo arm to rusfertide eventually. And this trial, of course, allows either the drug as single agent or in combination with a cytoreductive agent.
Okay, and I know that that's a drug that our community has a lot of excitement over, and I've heard some patients, share some, good results with me on that. So we'll be looking forward to more information on the results. So looking at the progress that's taking place in MPN research, the future really, it looks brighter than ever. So please stay tuned as we have updates from our sponsors who make these educational programs possible. So, Doctor, thank you so much for joining us today.
David, thank you very much.
Hello, everybody. My name is Meredith Manning. I work for Pharma Essentia, and I'm the president of the Americas. Pharma Essentia is a fully integrated, growing biotech company. And I wanted to really thank David for inviting us to join you all today. We are proud to sponsor MPN Cancer Connection, as we know it's such an important resource for the entire MPN community. Just to give you a little background, at Pharma Essentia, we've been an essential partner in the MPN community really for over 20 years. As you may know, we have an FDA product that was approved for PV back in November of 2021. And we would encourage you to learn more about the product, both the dosing, efficacy, and safety, and the profile of our product at pharmaessentia.com. I wanted to share with you that we have 2 clinical programs which are currently enrolling for patients. One is the Eclipse PV. This is a clinical study that we've started in the US and in Canada. And it's a really critically important study as we're looking at evaluating the new dosing regimen compared to our current dosing regimen, which is approved by the FDA. Our second clinical study is Exceed-ET. And this is a clinical study also happening in the US and in Canada. And this evaluates the potential of a new investigational ET therapeutic. Information on the study can be found at eclipsepv.com and exceedet.com. Your stories and experience are what drive us every day to do more. I would like to spend a couple of minutes sharing with you some resources that we've been very dedicated to create over the past year and the past couple of months. So I'm really excited to share with you the first resource, which is called the PV Pod, Stories from the Marrow. This is a podcast that will feature voices from the PV community, both clinicians as well as patients, as well as other advocates. And hopefully we can get some caregivers in there to share their information. We've heard over and over again that it's really important to have forums like you're doing today in order to be able to connect with other patients, with other caregivers and clinicians to stay informed and feel really empowered to take action in whatever MPN that you might be experiencing. Second, I want to share with you that we have a resource which goes into PV specifically. It's called What's Next PV. This is an online resource to help you better understand areas in which you might be experiencing during your PV journey. So please visit whatsnextpv.com and take a look. Finally, we know what's really critically important is as you talk to your care team about what treatment is right for you, it's really important that us as manufacturer provide you additional resources. So we have Pharma Essentia Source program. It is a resource for patients who have been prescribed a Pharma Essentia therapeutic or a Pharma Essentia treatment. The source provides personalized services, including access and payer navigation assistance. We look forward to continuing to advance treatments for even more blood cancers in the MPN space. I thank you profusely for your support and your partnership, and we are proud to stand alongside you in this powerful community. So thank you, David. Thank you, everybody, and warm best wishes to all of you. So thank you.
Hi, my name is Kristen Griffiths, and I work on the public affairs team at Insight focused on MPNs. I'm very pleased to be here today to represent Insight, and I would like to thank David and MPN Cancer Connection for having me and giving me a few moments to speak about our company and its commitments to patients. A little background on Insight. Insight is a Wilmington, Delaware-based biopharmaceutical company committed to making a difference in the lives of patients through scientific discovery. Rigorous science is at the core of everything that we do to develop, discover, and deliver novel medicines that will meet the serious medical needs in oncology and other diseases. We are committed to providing better outcomes to patients through the medicines that we develop and the education that we provide to support the community. One of our most important commitments is to ensure that the appropriate patients may have access to the medicines that they need. For this reason, we have developed a patient program called Insight Cares to help support patients and healthcare providers access their prescribed medication. For eligible patients, Insight Cares offers prescription drug verification, prior authorization support, free drug and copay assistance for those who qualify under the program's terms and conditions, as well as ongoing education and support from a representative. Patients who have concerns about access to their prescribed medication should contact Insight Cares for assistance. Information for patient access can be found at www.insightcares.com. Once again, that's insightcares.com. And we highly suggest that eligible patients enroll in Insight Cares even if you don't think you will need access initially. Circumstances can change, and if an eligible patient is enrolled, we will be able to provide the individual assistance more quickly if needed. Regarding clinical trials, we are currently enrolling in clinical trials for MPNs. If you're interested in clinical trials, please contact your healthcare provider. Detailed information about Insight's clinical trials can be found at insightclinicaltrials.com. Once again, that's insightclinicaltrials.com. We strive to enhance the patient community to integrate an authentic patient voice through our initiatives. Partnerships like the one we have with MPN Cancer Connection have really been key in helping us understand the unmet patient need and caregiver needs, including disease awareness, and also providing a true authentic voice in the MPN community through the materials that we create. We host a website called voicesofmpn.com where we provide access to MPN information, patient stories, access to information on MPN community events such as Facebook Live programs, patient meetings, podcasts, and also a symptom tracker. So I highly suggest that you check out voicesofmpn.com to see that information. And in closing, I just wanted to say thank you again so much for giving me a few moments to speak to you today. Programs like this allow Insight to utilize our resources to help improve the lives of individuals impacted most on the diseases in which we work. So thank you so much and have a great day.
Hello, my name is Elsa Levita. I'm Director of Patient Advocacy at Morphosis. It is a pleasure to be here today, and thank you to David and the MPN Cancer Connection for the opportunity and partnership. Morphosis has one FDA-approved therapy, and our pipeline consists of investigational cancer medicines in mid and late-stage development. This includes pelabresib, our investigational BET inhibitor. Pelabresib is being investigated in the phase 2 MANIFEST study in combination with ruxolitinib, a JAK inhibitor, in patients with myelofibrosis and as a monotherapy in patients with myelofibrosis and essential thrombocytopenia. Pelabresib is also being investigated in the phase 3 MANIFEST-2 study in combination with ruxolitinib as a first-line treatment for myelofibrosis. Pelabresib is an investigational, orally administered small molecule, or in other words, a pill, designed to inhibit the activity of a family of proteins called BET proteins. The BET family of proteins is an emerging potential therapeutic target that can modify the underlying drivers of disease in myelofibrosis. JAK inhibitors, by influencing the JAK-STAT pathway, have already been approved to treat myelofibrosis in intermediate and high-risk patients. Combining BET inhibition and JAK inhibition in preclinical studies suggests the potential for the two to act synergistically to alter the underlying disease process in myelofibrosis. MANIFEST-2 is a global, multi-center, double-blind, randomized study comparing pelabresib in combination with ruxolitinib versus placebo plus ruxolitinib in patients with myelofibrosis that have not been previously treated with a JAK inhibitor, otherwise known as JAK inhibitor naive. A double-blinded study is one where neither the patients nor the researcher knows which treatment the patients are receiving until the clinical trial is over. MANIFEST-2 has recently reached full enrollment and is no longer recruiting. More than 400 patients in MANIFEST-2 were randomly assigned to two groups of equal size. The first group is receiving pelabresib in combination with ruxolitinib, and the second group is receiving placebo plus ruxolitinib. Understanding that spleen enlargement reflects myelofibrosis disease activity and can cause significant pain and/or discomfort for patients, the primary endpoint of the MANIFEST-2 trial is the proportion of patients who achieve a 35% or greater reduction in spleen volume 24 weeks after starting treatment, known as SVR35. Since we know that people living with myelofibrosis can experience severe symptoms that may diminish their quality of life, we designed the study so that the key secondary endpoint of the MANIFEST-2 study is the proportion of patients achieving a 50% or greater improvement in the total symptom score, as measured by the Myelofibrosis Symptom Assessment Form version 4.0, 24 weeks after starting treatment, also known as TSS50. As we release data from the MANIFEST and MANIFEST-2 studies, we will work closely with the MPN Cancer Connection to ensure regular updates on our studies are shared. The top-line data from the MANIFEST-2 study will be available by the end of this year. As a reminder, pelabresib is an investigational new drug not approved by any regulatory authority, and there is no guarantee that it will be approved. At Morphosis, we are honored to work with patient advocacy groups like the MPN Cancer Connection serving the blood cancer community. Thank you so much for the opportunity to be here today.